How are you? I'm Dr. Rutherford. I'm a certified functional medicine practitioner, chiropractor since 1979.
Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractor.
And today we're going to talk about hyperhidrosis, which means a lot of sweating. It means like sweaty palms. Could be underhand, could be underhand, could be underarms, could be under your feet. And a lot of people may or may not realize that there's an imbalance going on there in your system. Some people actually, and although this may or may not apply specifically, a lot of women will come in and think they're having hot flashes, and then I'll say, are you hot? Are you flushed? Or are you just sweating? And they'll say, I'm just sweating. And I'll say, oh, it's not the same thing.
Right,
so
exactly.
A lot of you who have that, we're going to be talking about the non-hot flash sweating today. And it's something that we see frequently. If you watched enough of our videos, you'll find that there are certain things that repetitively seem to show up in what we do. Immune systems, one, gut is all over the place. We're talking about guts all the time. Thyroids, we talk about a lot of thyroids. And we probably talk less about the stress mechanisms than anything else. We've talked about them. We've talked about them prominently, but probably not as much.
Okay.
I think I'll go back and review that.
We've hammered it, but go back through it.
So stress mechanisms are the other thing that we tend to talk about a lot. And this hyperhidrosis can be connected to that. In fact, in our patient population, it is more often than not connected to that. But as Dr. Gates schooled me on before this, or as he pretty much pointed out to me relative to some of the patients that we have, that there's a significant spectrum on pretty much on all chronic disease. But there's a spectrum on this sweating problem to where a lot of people come in. First thing I do when I meet them is usually I shake their hand. For those of you who have been here, I'm usually checking out to see if your palms are sweaty, because a lot of times it gives me a heads up right away that we might be dealing with a sympathetic response, which Dr. Gates is going to talk about. But then on the other end of the spectrum, as it moves up to more seriousness, you can have serious hyperhidrosis. There can be a lot of different reasons for it. It can be very uncomfortable to have it, and very difficult to deal with. Even here in this, we're here in Reno, Nevada, for those of you who are watching us from the East Coast or anywhere else. We're the high desert. Today it's a little humid actually, but for the most part, humidity is almost non-existent here. And if you're sweating here, it's you for the most part, unless it happens to be today where we're having a teeny bit of humidity here. So hyperhidrosis. Was that an
Yeah, that's a good overview. Absolutely.
Anything you want to add to that?
Nope.
Okay, so hyperhidrosis, there are different forms. This is where the class begins, okay? There are different forms of hyperhidrosis. One is the more common one that we talk about, and then there are several as you move higher into the spectrum of sweating. You're always wet, your feet are always wet in your shoes, your hands are clammy, you don't want to shake hands with people, etc. Dr. Gates is going to go through that now. So what are the different, you're going to go through all the different forms? What are the different forms of hyperhidrosis?
Well, the classification is not really perfect, and I really don't like the classification, but basically it's set forth that primary hyperhidrosis tends to be more congenital, more familial. So if you had hyperhidrosis before the age of 18, probably there's a genetic component to it, or many members in your family have it, versus secondary typically is more later onset in life and it's associated with other conditions. Now there's also within this classification scheme focal versus generalized, and typically they'll say focal is more primary and generalized is more secondary. We haven't seen that to be true, but focal more means like if only one hand is sweating, there's reason to pay attention, versus if it's just generalized, if it's your armpits, if it's your hands, it's your feet, and you've had it since you were a kid, most likely it's a genetic issue, versus if you're an adult and it's just all of a sudden it starts happening, probably it's one of your medications. Maybe you have a thyroid problem, you have an endocrine disorder, maybe you have a certain type of cancer that needs further verification and assessment thereof. So that's kind of the generalized classification scheme.
Sounds like we're done.
We're not. Hyperhidrosis. And it's, as Dr. Rutherford alluded to, this can be a disabling condition. This can be really, really a nuisance to a lot of patients who have this. They're afraid to shake people's hands because, you know, they don't want people to judge them, to think that they're stressed out when they're really not stressed out, and they're only maybe stressed out because they're worried about people judging them because of their sweaty hands. And it can be associated with foot problems, because patients who tend to sweat this much down in their feet, you're more likely to get bacterial and fungal infections. And it's just a disabling condition. It's not fun to have.
Yeah. So for those of you who are watching who are going to be attracted to the title, Hyperhidrosis, Solutions for Sweaty Hands, Feet, and Axillas, as Dr. Gates said, if you have it in just one area, it's definitely cause to pay attention to it. But the reason that we're talking about this subject is we've had the opportunity to observe this pretty much across the spectrum, is the word of the day, pretty much across the spectrum of patients that we have come in, because if you have not watched any of our videos, you'll find that the 4 things that I cataloged in the beginning, the thyroid, the gut, immune problems, and stress hormones, are the 4 things that we find to be fairly consistently there for the chronic pain patient. So it may even be that some of you who are having this hyperhidrosis might also be having anxiety or panic attacks, or you may have, there's a variety of things that can be involved with this, okay? But I guess we're gonna pretty much stick strictly to the hyperhidrosis, because we do a lot from observation and experience. There's a lot of research out there. Dr. Gates does his best to get his hands on pretty much all of it. And so we'll have patients come in, and as they'll have chronic fatigue or fibromyalgia or peripheral neuropathy or anxiety or panic attacks, and they'll have hyperhidrosis. And then we'll start putting them through our logarithm, our program for chronic pain. Their sweating will get better. And then there's our patients whose sweating doesn't get better. And these are the ones that the research and experience and trial and error have come to help. Dr. Gates is doing all the treatment now to understand the potentials of those getting better, what the causes might be, how they might get better, and in some cases, how they might not get better. In the really, really severe cases that maybe the research hasn't
completely solved yet. And we have some new data for those of you watching.
So that's where we're going to go from here.
And I want to highlight on that. So you illustrated that very well. Thank you. That's perfect, because as
my job.
As Dr. Rutherford was saying, we have a lot of patients with hyperhidrosis who really, they improve. And, you know, it's
most.
They come in, exactly, most. They come in, they say, you know, my hands are sweaty all the time. And we put them through our paces, through our program. All of a sudden, their hands aren't sweating, their feet aren't sweating, they're very happy.
And we're kind of not treating them for that. We're treating them for their fibromyalgia, their peripheral.
And then there are the tough patients that we'll get into as well. And on those other patients that you alluded to, relative to those who have anxiety disorders, those who have peripheral neuropathy, by getting to the underlying cause of the problem, that's where we've had tremendous success. So using anxiety as a model of stress, if you're constantly in a state of fight or flight, what the literature talks about relative to hyperhidrosis is that your sympathetic nervous system is too dominant. We have 2 kind of automatic nervous systems in our body. One is called the sympathetic nervous system. It prepares you to fight or run as fast as you can. And we have the parasympathetic nervous system, which helps you to rest and digest. So the fight-flight response is, you know, commonly referred to as fighting the lion, whereas the rest and digest response is the lion after it made its kill and it's sleeping for 28 hours.
If you want to know which one you're in, if you're in parasympathetic, you're relaxed, you're calm. Most of our patients are not there.
Exactly.
If you want to know if you're in fight-flight, you're not relaxed and calm. You probably have panic attacks or anxiety, or you have a difficulty going to sleep at night. Your mind's going a million miles an hour. You wake up in the middle of the night. You can't go back to sleep. Those are kind of like some kind of clinical ways to kind of see where you might be on that spectrum. I'm using that word today. I like that word, spectrum.
And so for those of you in that fight-flight spectrum, you're going to be basically sending more signals through your sympathetic nervous system. One of the results of sympathetic activation is sweating. And so that's why you're going to get sweating We have a tendency for more with the hands. You can also get the armpits and the feet, but the hands tend to be one of the more disabling features for a lot of people. Whereas with peripheral neuropathy, here's another example. So we treat a lot of patients who have what's termed small fiber peripheral neuropathy. Now, peripheral neuropathy is where the nerves die and degenerate, typically down in the feet first, spreading up to the knees, and then involving the hands. Now, sometimes the small nerves are preferentially affected, and these encode functions such as pain, sweating, blood flow. And so these patients are going to have a tendency for a lot of sweating. And by the time we basically go back in and rehab their nerves, we get to the underlying cause of their problem, whether it be prediabetes or an autoimmune issue, the sweating tends to come back to normal.
Yeah, so if you're low on the spectrum, if you will, you're going to come in here, or you're going to have fibromyalgia, peripheral neuropathy, or anxiety, or dizziness, or vertigo, or migraines, or balance problems. All of these entail, or all of these have as a part of their cause, this overfiring sympathetic nervous system, sympathetic dominance, fight, flight, and it's a common cause to your hyperhidrosis. When you start getting into, let's say, more severe levels of hyperhidrosis, or higher on the spectrum, if you will, now you're going to have that plus other potential causes.
Exactly. There can be not only the
or other
congenital
potential
aspect,
causes causing
also,
that which is causing your hyperhidrosis.
Right. And then the anxiety feeding in too, creating
I'm
a
asking,
vicious
you
cycle.
don't have to like say yes.
Oh,
If
okay.
I'm wrong, I don't want them to like get the wrong thing.
The answer is yes.
Okay.
To be specific.
I'm just using my background in human anatomy and biochemistry to, sometimes I'm sitting here trying to make the program interesting, although a lot of you get upset because I interrupt, and I get that. but you know, half the time I'm trying to learn here too, you know, so I can put it together, because he is the brain guy and my background is human anatomy, biochemistry, functional medicine, and chiropractic. So that's, and sorry that we laugh occasionally, but we think each other is very funny. So,
Exactly.
For a lot of different reasons.
Yeah.
So, okay. So we'll talk about those. Talk about
and let's go into the congenital.
Significant. Now, this is, you're sweating in one arm, or you're doing all the other things, and nothing's getting better. This is where we're going with this congenital.
So the newest of the newest data, we just got it. It was 2016. Had to read through a lot of references to finally find the nugget. And basically, it was just found that those of you who have congenital hyperhidrosis, familial hyperhidrosis, you have what's termed an aquaporin defect. Aquaporins move fluid from one area to another, or move other chemicals from one area to another. And in your sweat glands, you have too many pores. That's what they've now shown. And so you have more pores to basically create sweat than the average individual. It's not that you have too many sweat glands. That was one theory that hasn't been substantiated, but it appears as though you have too many pores in your sweat glands, creating more sweat than you want there to be. And that's the cause of the congenital hyperhidrosis. And
So
that's
that
where
doesn't sound very correctable.
And so that's where it's more difficult. And that's where we're working with some patients on other therapies that we'll go into that are going to be non-functional medicine, functional neurology therapies, because there's just that anatomical limitation.
I should have said it doesn't
that
sound
we
very
have
correctable with what we do.
With what we do, exactly.
That would have been more accurate.
But there are some other treatments that are proving to be very successful, and some cool ways to go about it. So that's the new data on the congenital hyperhidrosis. But the congenital hyperhidrosis patient can have other secondary causes associated with it. So one very obvious one is the anxiety aspect. And we attach references where they talk about a lot of this anxiety with hyperhidrosis. So they're anxious because they have hyperhidrosis, and that creates
vicious cycle.
The vicious cycle, and causes the problem to be worse. But you can also have a thyroid disorder on top of your congenital hyperhidrosis. You may have a tumor in your adrenal glands, which we have had to check patients for to see if they have those sorts of issues. And other times medications have to be considered. Sometimes medications will be used to help with the anxiety, trying to help the hyperhidrosis, but they can actually provoke the hyperhidrosis. So it's this fine balance that comes into play. It's not a simple fix. But that's kind of the generalized overview of everything else going on with the hyperhidrosis patient that has to be ferreted out. And there are medications that are commonly employed to try and help the hyperhidrosis patient, but they're imperfect as well because they'll have side effects. Lots of times they'll cause drowsiness. Basically, these medications are trying to block nerve transmission through this sympathetic nervous system. And there are two primary chemicals involved with sweating. One is basically adrenaline, and the other is acetylcholine. Acetylcholine is one of the major neurotransmitters in our nervous system. And so when you take medications that block adrenaline or acetylcholine, frequently patients will feel tired, they'll feel lethargic. So that is the major obstacle for a lot of doctors.
And although this may not fit in, okay, anywhere in our categories, we do hear, and I mentioned it beforehand, I asked our cases, this have to do with the ladies who come here think they're having hot flashes, but their swing says not exactly. But I do think I want to mention it, only because I hear it all the time. Somebody might be looking this up, and maybe they are thinking about that. And basically what's happening is, look, menopause, but most people come and go, I'm going through my change, I'm going through menopause or something like that. My first question will be, are you actually getting a hot flush, or are you just sweating? And frequently women will say just sweating. People, and today we think menopause is a big problem because it's kind of sort of a time when people go through bad problems. And I'm not a guy talking about this who doesn't know what he's talking about, because I hear this every week at least, or every couple of days. And so I get it that it's a difficult time, but we have 159 million chronic pain patients in the country now, pain sufferers or more, according to all of the people who are finding this. One saying it's under 30 million. I think 159 million, somewhere around the 59% that they just said 2 weeks ago. So there's a lot of people going into menopause who maybe aren't in the best condition that they could be in to withstand that type of a change in their body. Menopause is already a strain on the adrenal glands. Even if you're healthy, it's a strain on the adrenal glands. There are people who go through menopause fine, okay? They probably are already kind of healthy going in. So your adrenal glands are a big player in producing the sweat. So if you're going through menopause and you have sweating, but not really hot flashes, or you're getting sweating and you're wondering if you're going through menopause or you're not going through menopause and you're getting hot flashes, it's usually going to be the stress mechanism that we're talking about. It's usually going to be this fight-flight syndrome where and again, that goes back to maybe you get anxiety for no reason at all of a sudden, maybe suddenly you develop panic attacks. Maybe it just is simply that your brain's going a million miles an hour and you can't fall asleep. You wake up in the middle of the night, you can't go back to sleep. That's kind of the connection there. I don't know where that apparently doesn't fit into any of this specifically, but I just felt it was
there's some overlap.
The framework of this to mention it.
The overlap is such that the reason why people have hot flashes or women specifically, is because they don't have enough estrogen. So the brain is trying to elicit an adrenal response because the adrenal glands become responsible for making estrogen through basically chemical processes of DHEA being converted, and some progesterone is converted there as well. So the brain is trying to create an adrenal response, and doing so, it fires the sympathetic nervous system like we're talking about, and that creates increases in blood flow and sweating, and that's why they have the hot flash.
Exactly. Yeah. Exactly. So I just want to mention that for those of you, the one of you who might have tuned in to hear about that. So, and did one limb?
One limb, if you have hyperhidrosis in one limb,
issue.
You need to really pay attention. Likely it may be a type of skin cancer, it may be a type of focal peripheral neuropathy, but if you only have it in one limb,
sympathetic dystrophy.
Reflex sympathetic dystrophy, if you have it
you can
in
look
one
up
limb,
our talk on reflex sympathetic dystrophy. If that sweating is accompanied by severe pain, it's part of that neurological response in that limb, arm, leg.
So you need to have a further evaluation.
So as we said prior to this, we're to treatments now, right?
Right.
So as we said prior to this, as I mentioned prior to this, and I corrected myself, the more severe cases tend to require a very direct response. So many, I mean, I'd say 80 or 90% of people come in here who have hyperhidrosis. It cleans up when we're working with their stress mechanisms and their thyroid and their gut and their immune system to fix their other things like their fibromyalgia and stuff. But then there's the ones that don't. And the treatments, the medical treatments for them there are a lot of medical treatments for them. I'll leave to Dr. Gates to tease out which are the medical treatments that are required. For example, in the area where you have just too many pores, I don't know, doing what we do isn't gonna help that, because you just have too many pores and you have a natural sweating response and you sweat more. than the other people. But I'll leave it to Dr. Gates to go through the treatments and maybe delineate which ones are necessary and which ones you might be better served by doing maybe a less aggressive, approach first.
Mm-hmm. Probably the least aggressive approach is iontophoresis. Iontophoresis basically entails using direct current, so electricity, to push whatever medium, it could be a fluid, it could be a chemical, into an area. So in physical therapy, they use iontophoresis, where they use current with ultrasound to push like corticosteroids, like prednisone, into an area to alleviate or to relieve inflammation. With iontophoresis, as it pertains to hyperhidrosis, in essence, we're using direct current to push basically water into the sweat glands. So I'm not really sure why it works, but it seems to maybe overwhelm the sweat glands, so it shuts it down and it stops producing so many secretions. So that's iontophoresis. We attached an article, you can find it, where an engineering student basically created an iontophoresis device for, I don't know, it was like less than $20 for those of you who are ingenuitive. And he had great success with it for his palmar, meaning his hand, hyperhidrosis. But if you have axillary hyperhidrosis, I don't think his invention will work satisfactorily for you. Then there's radio frequency devices. There's microneedling. This is used in dermatology, where they go in and basically with needles, they try to destroy the sweat glands. Surgical interventions are actually pretty common in this realm. So if you fail the medications, let's say you take the oxybutynin, which is an anticholinergic, and maybe you're too tired from it, or it wasn't adequate in helping your sweating, then they'll go in and they'll actually surgically cut the T4 ganglia, basically, for the sympathetic nervous system. So they'll, in essence, cut your sympathetic nervous system at a specific spot, and that seems to help the hyperhidrosis. But that is a pretty radical procedure. In our book, we're not the ones suffering with hyperhidrosis, but we really recommend trying all these other things first.
Yeah, that's a tough one, because I'm trying to diplomatically. We're not anti-medicine. Right. As if you watch any of our stuff, hopefully we've said that on every single presentation we've ever done. It's all challenging because the medical doctor who is evaluating you for clinical pathological hyperhidrosis, in other words, for cancer medications, or even if they don't know what it is, okay, they're going to be using these tools, period. They're not really going to be, they don't have a frame of reference that there are less invasive procedures that could help most hyperhidrosis. Some of them, these procedures are going to be the person's only choice.
True.
That's what I'm trying to tease out here.
So many of you, if you're watching this broadcast and you have hyperhidrosis, you go to your doctor, he has a list of things that he's going to potentially do. First of all, he's going to say, okay, is this congenital? Is this more generalized and secondary? Is it come on later in life? If it's more later in life, he needs to make sure you don't have cancer or a thyroid problem, as an example, that's causing it. And then basically they're going to put you on a couple different medications. They may try you on a beta blocker. They may try you on an anticholinergic, a couple different derivations thereof. If you fail that, you're sent to the dermatologist. The dermatologist may talk to you about iontophoresis. They may not. They may recommend the microneedling procedure, some radio frequency device that they have. And if that fails, then you're going to be referred for surgery. I mean, that's your standard course. As Dr. Rutherford is saying, we see a lot of hyperhidrosis patients. We've seen some hyperhidrosis patients who haven't really improved because they have more of the congenital aspect. We've seen a lot who have improved by addressing their underlying anxiety, their underlying fibromyalgia, their peripheral neuropathy. Yeah. Great majority in our clinic. That's what we've seen. So there's this whole other area that you probably may not have been aware of, your doctor may not have been aware of, that is possible for the hyperhidrosis patient. While we fully admit that for some of you, these other more invasive procedures are what we have to go to in order to help you because of the aquaporin issue in the sweat glands.
Yeah. Yeah, and again, that's appropriate. I mean, do we admit or whatever? Our approach is really there's a need for everything. Okay, we've kind of confused what they are, but the medical profession has its strengths. Its strength clearly is not chronic problems, or we would not have now anywhere from 130 to 159 million chronic problems running around in this country, depending on who you're what research you're referring to. But for pathological problems, congenital problems, things that where tissues have just gone wrong, then surgeries are indicated in a variety of areas for those types of things. Even medications are sometimes indicated. I don't know, not particularly maybe for this. I think most of the patients who have medication, who would respond to the medication, would respond to the techniques that we're utilizing here.
I know
Would
what you
that
mean.
be incorrect?
It's not quite correct, especially for those more severe patients.
So bottom line is I guess if you have watched this protocol, the bottom line is probably best to get an evaluation from us or from a chiropractic neurologist, because this is more often a neurological problem with other areas that would need to be definitively diagnosed out. Right. And I think a board certified chiropractic neurologist, or even a neurologist, I don't know, might be. No, it would probably have to be a board certified chiropractic neurologist. No, again, no disrespect intended, but the neurologist doesn't really play in this field of alternative options.
Most neurologists do not.
Most don't. And there's an initial growing interest in that in the neurology field, when there is, but it's very, very nascent. It's just in its very beginning. Right. So you would need to get evaluated by someone who could say, yes, this could respond to a conservative treatment, and here's what they are, and no, you're going to really need to look at a surgical or a medical option.
Exactly. Yeah. I think we pretty well covered it.
Okay.
So if you have any other recommendations for other broadcasts, let us know what those are. You can access all the references that we have on today's broadcast at powerhealthtalk.com. If you have other inquiries that you want to see on that webpage regarding the adrenals or female hormones, just search adrenals, search hormone replacement therapy in the search tab, and lots of videos will come up. And we appreciate you watching, and we will see you next week.
Okay.